Sorry for this. Till we fixed the second presentation with Dr. Mohammed Shakir, let's move to the third presentation. It will be by Dr. David Kendler. He's a clinical professor of medicine and endocrinology in the University of British Columbia, Vancouver, in Canada. He's the president of Pro Health Clinical Research, a North American leading center in osteoporosis, clinical research, and clinical care. The lecture will be about the updates on anabolic therapy. Just again to remind you, if you have any question, you can send it through the SMS with 05599175530.
The Osteoporosis Society, and this talk will be on bone anabolic therapy and where we're headed with that in the future and some of the key updates. I'm sad that we aren't able to meet in person. However, perhaps in 2 months' time, some of you will be in Barcelona to see the Gaudi architecture and the International Osteoporosis Foundation meeting, and hopefully I can see some of you at that point. So I've had the pleasure of being on a number of clinical trials to do with most of the agents that we have for osteoporosis with a variety of sponsors. And so the question, why are we so focused on anabolics now? And there are a number of reasons. First, there is a need for therapies that act more rapidly and more effectively to prevent fractures, and the special need is for non-vertebral fractures. The anti-resorbers do a very good job with vertebral fractures, but we really have a gap in our ability to prevent non-vertebral fractures. We now have new insights into the relationship between the change in bone density and reductions in fracture risk, and I'll present that at some length, and that certainly opens opportunities for anabolics. And we know that there's an inability of bisphosphonates to provide ongoing anti-fracture efficacy. There's that plateauing of effect, and there are, of course, concerns over long-term bisphosphonate therapy. And finally, we have a concept of imminent fracture risk. That's the risk of fractures in the year or two after an index fracture. And that helps to define a population who are at very high fracture risk and certainly candidates for our best therapies. So this story really begins about a decade ago when Matt Austin looked at the FREEDOM study. And that, of course, was a trial looking at patients randomly assigned to denosumab or placebo, postmenopausal women with osteoporosis. And what Matt is looking at here is the change in total hip bone density by the end of 3 years on therapy, plotted against the percent of patients with new or worsening vertebral fractures. And so what he found is that the greater the increase in total hip bone density, the less the risk of new vertebral fractures. So there was a direct relationship to the change in bone density with anti-fracture efficacy. And the dotted line represents placebo, so although upshifted, there also was a relationship. In general, those patients who lost more hip bone density had a higher risk of new vertebral fractures. And when he looked at non-vertebral fractures, the curves actually lined up, and it was a pretty linear approach. So that's the first indication from our clinical trials with denosumab, that there's that close relationship between change in total hip bone density and prevention of fracture. This observation was extended once the extension to the FREEDOM study was complete, and here Serge Ferrari looked at the expected one-year incidence of non-vertebral fractures plotted against the total hip T-score at any time during treatment with denosumab. So these are only patients who are on denosumab, and you can see that the lower the T-score at total hip, the greater the expected one-year incidence of non-vertebral fractures. And this was also seen, reported by Felicia Cosman in the ARCH study, that no matter if patients were on alendronate or romosozumab, the same thing happened. That is, the total hip bone density T-score at month 12 of the study after alendronate or romosozumab, the lower the T-score was, the higher the expected one-year incidence of non-vertebral fractures. And it didn't matter whether patients were on alendronate or romosozumab, bone density was what mattered. And so our most recent update is the FNIH SABRE study. And this is an initiative which is sponsored by the ASBMR, the American Society for Bone and Mineral Research. And its goal is to present to the NIH and the FDA data supporting the use of total hip bone density as being a surrogate for fracture. And as you know, at present, new agents require a fracture study in order to gain approval. And that really limits what we can do because ethics will prohibit us doing fracture studies, for instance, in high-risk populations. So the FNIH SABRE study took individual patient data from about 62,000 participants in 16 clinical trials, which involved bisphosphonates, CERN, denosumab, adanicatib, and teriparatide, all against placebo, where we could determine fracture risk and we could determine change in total hip bone density. And Richard Distel generated what he called a surrogate treatment effect, and which was defined as the minimum treatment effect, that would be change in total hip bone density, that would be reliably predictive of fracture. And this was individual patient data, so very robust data set. And what he found for all fractures is that there was a close correlation between the change in total hip bone density plotted on the horizontal axis and the hazard ratio for all fractures, such that with patients who had greater increases in total hip bone density, the risk of fracture was reliably reduced. And he plotted out the 95% confidence interval, and the STE, or this surrogate treatment effect, was defined at where the 95% confidence interval crosses unity. So anything less than a 1.83% increase in total hip bone density would not be significant, but anything greater than that would lead to a reliable reduction in the risk of all fracture. And in his publication, he looked not just at all fractures, but categories of vertebral fracture, hip fracture, and non-vertebral fracture. And you can see that the STE varied between 1.42 for vertebral fracture and for hip fracture, 3.10. And so that means that if you want a reliable reduction in hip fractures, then you would need only a 3.10% increase in total hip bone density. And this, he thought, and the group thought, would be a reliable enough surrogate that the FDA should be able to accept that, at least on a clinical trials basis, as a valid surrogate endpoint. And so how that translates is that if you looked at, let's say, just a 2% increase in total hip bone density, we would expect to see a 28% reduction in vertebral fractures and a 16% reduction in hip fractures. And you can see if you take increases in total hip bone density of 6%, which you can achieve with the anabolic therapies, then the reduction in vertebral fracture would be 66%, and the reduction in hip fracture 40%. And so this is the direct correlation between bone density changes, which can be achieved with anabolic therapies, much less likely with anti-resorptive therapies, in reliably reducing fracture risk. So let's move on to the therapies. And we have two classes of bone anabolic therapies, those acting on the PDH1 receptor, which include PDH1 to 34 teriparatide, whole molecule parathyroid hormone, although not indicated at present for the treatment of osteoporosis, and PDHRP, which is abaloparatide, that's an analog of PDHRP. And in addition to that, we have sclerostin antibodies, and I'll present the data on romosozumab and a new one called setrusumab that you may have heard of. So the first question to ask is, what greater benefit does anabolic therapy afford patients as compared to the less expensive and more convenient anti-resorptive therapy? And in particular, if we focus on the very high-risk population for whom the anabolics would be perhaps a first choice. And so for that, we need a head-to-head trial. And the first head-to-head trial of anabolic versus anti-resorber was our Vero study, where we compared 2 years of weekly risedronate with 2 years of daily teriparatide in about 1,400 postmenopausal women. And all of these women had at least 2 moderate or 1 severe vertebral fracture. And you can see that the rate of the cumulative incidence of all clinical fractures separated out at around the 6-month time point, and by the end of the 2-year clinical trial, there was about 50% reduction in the risk of clinical fracture in those patients on teriparatide as compared to risedronate. That's not compared to placebo. The placebo curve would be much higher. But this illustrates that there's a much greater efficacy in these patients with severe osteoporosis, and as well a more rapid onset of action when in patients treated with the anabolic. PDHRP, the other agent acting on the PTH receptor. PDHRP was discovered way back in the late 80s, and it's known to be the mediator of hypercalcemia of malignancy in cancer patients. It's important probably for growth plate development and the development of the skeleton. And PDHRP binds to the PTH1 receptor and activates second messengers just as PTH does. We know that if you infuse PDHRP, it increases 1,25-dihydroxyvitamin D. That's one of the mediators of hypercalcemia. But like teriparatide, if you give PDHRP intermittently, it stimulates osteoblasts and it can be anabolic to bone. And so in the lower panel, you can see the PDH1 to 34 sequence, the business end of the parathyroid molecule in red. You can see PDHRP, the native molecule, which has some homology to parathyroid hormone. The green are unique amino acids. And you can see abaloparatide, which shares some sequences up to the first 22 amino acids with PDHRP. And then later there are substitutions of amino acids, which give it a different pharmacologic profile as compared to PDHRP. So how does this pan out? If we look at the comparison of abaloparatide to teriparatide in this dose ranging study, focusing in here on P1NP, that is a marker of bone formation, you can see that teriparatide does lead to sustained improvements or increases in P1NP over the half-year, 24-week time interval. And this is a dose ranging study, so focus on the blue line, which is the indicated 80 mcg daily dose of abaloparatide. And you can see that there are similar increases up to 4 weeks, and then as you come out to 24 weeks, teriparatide does stimulate more anabolic marker, more P1NP. Placebo is in the black here. If we look at C-telopeptide as a marker of bone resorption, then again, teriparatide 20 microgram has a greater increase in stimulating osteoclastic bone resorption than abaloparatide. And so the argument is that this lesser resorptive activity of abaloparatide may open the anabolic window, and that may result perhaps in this greater increase in bone density. Here we're looking at total hip bone density in abaloparatide going up by about 4%, teriparatide about 3%, with greater increments with abaloparatide, at least at the hip site, similar at the spine site as compared to teriparatide. If we look at fractures, the primary endpoint is vertebral fracture, and just like clinical fractures, we saw teriparatide and abaloparatide being roughly the same in reducing the risk of clinical fractures and vertebral fractures as compared to placebo. If you cut into a category of major osteoporotic fractures, we see that abaloparatide has superior efficacy to teriparatide, but this was an exploratory endpoint, so not a primary or secondary endpoint of the study. So in summary, for the PTH receptor anabolics, teriparatide and abaloparatide are both effective in preventing fractures, stimulating bone remodeling, and so remodeling-based anabolics. Both require daily injections. Patch has not worked for either of them. abaloparatide has an advantage in that it can be stored at room temperature versus teriparatide that must be refrigerated. There is slightly less resorption with abaloparatide, slightly less anabolic effect in terms of bone turnover markers. With both of these agents, a follow-on with anti-resorber is required. And as a footnote, we now have greater than 20 years experience with teriparatide, and we have not seen osteosarcoma risk. And on the base of that, the boxed warning has been removed, at least from the US label of teriparatide and abaloparatide. So moving on to sclerostin antibodies. Sclerostin is a protein made by the osteocyte and the osteoblast, and it is an inhibitor of osteoblast action and formation. And so if you have an antibody to sclerostin, romosozumab, you have potent anabolic effects on bone, and it differs from teriparatide. Romosozumab, by neutralizing sclerostin, encourages the conversion of bone lining cells into osteoblasts. It stimulates mature osteoblasts to produce more bone, and it stimulates the conversion of progenitor cells into mature osteoblasts. And it has a second effect. It has a dual effect on bone, and the second effect through the rank-rank ligand system. By neutralizing sclerostin, it reduces the formation of rank ligand and so acts as an anti-resorber, and so a combination anabolic and anti-resorber. And the effect of that is an increase in P1NP, interestingly early in the course of monthly injections of romosozumab. And then as one continues monthly injections out to the end of 12 months, the anabolic marker comes back down to baseline. The CTX, marker of bone resorption, is inhibited, about a 50% reduction in CTX, and that more or less maintains out to the end of the 12 months and even out to the end of 24 months. But the anabolic effect self-regulates. And that in comparison to teriparatide in the same study, where you can see marked increases in P1NP that continue as long as teriparatide is continued. And of course, the stimulation as well of the CTX as a marker of bone resorption. Just to show you the profile, if you give monthly doses of romosozumab, initially there's a marked increase, about 150% increase in P1NP. And as you get further out in therapy, that increment after injection of romosozumab becomes less and less. And CTX maintains suppression. And that results in increases in bone density, and here you can see the indicated dose of romosozumab in green, superior to teriparatide in terms of spine, and especially hip and femoral neck bone density changes. And I'll show you more on that later. If you go out to 2 years on romosozumab, as the phase 2 study did, you can see that there's a flattening out of the curve. So the greatest increases in bone density occur in the first year of romosozumab therapy, with lesser increments in the second year. But illustrated here is that if you stop romosozumab and give nothing, you have resolution of effect and return back down to baseline, both at spine and hip. So it's important to follow on with anti-resorptive therapy in order to maintain that anabolic benefit. And there are 2 trials which looked at romosozumab initially in the FRAME study versus placebo. And its primary endpoint was incidence of new vertebral fracture at 12 months. And you can see that there is a hazard ratio of 0.27, about a 70% reduction in the incidence of new vertebral fractures in those patients on romosozumab as compared to placebo. And then all patients were crossed over to denosumab, and at the end of the second year, that is a year of placebo followed by a year of denosumab, the placebo group had greater vertebral fractures than those who were given a year of romosozumab followed by a year of denosumab. And the risk reduction at the end of the second year, the hazard ratio about 0.25. And you can see that the time to the first clinical fractures, as with teriparatide, begins to separate at about the 6 to 9 month time point and remains separated through into the time when patients were all given denosumab. And so this is the legacy effect of the anabolic up front, giving a persistent reduction in the risk of clinical fractures, even after patients are transitioned to anti-resorber. The ARCH study, the second study for approval of romosozumab in postmenopausal women with vertebral or hip fracture, looked at comparing romosozumab to alendronate in these women at very high risk, and its paradigm was different. It gave a year of romosozumab or a year of alendronate to these severe osteoporosis women. And then following that, all patients were transitioned to alendronate. This was a smaller study, numbering about 4,000 patients, and the primary endpoint was fracture. And so the incidence of new vertebral fracture at 24 months in green are the patients who were treated from the beginning on alendronate, in the purple, those who transitioned from romosozumab to alendronate. And you can see that at the end of 2 years of that sequence, there was about a 50% reduction in the incidence of new vertebral fractures if the anabolic was given up front. Interestingly, this 11.9% risk of new vertebral fractures in patients on alendronate, so this is not on placebo, is just about the same as what we saw in the Vero study in patients on risedronate. And this represents the residual burden of illness in these patients who are not given the opportunity to take a bone anabolic therapy. And in the ARCH study, again against alendronate, the year of romosozumab up front provided that legacy effect with ongoing reduction in clinical fractures. Even as every patient, all the patients were on alendronate, there still was separation of those two curves. And the increases in bone density were certainly much greater with romosozumab, about a 14% increase in bone density in these women given Romo for a year, and then followed with alendronate, a plateauing of effect or stabilization of bone density as compared to those who were given alendronate straight through. So what about cardiovascular effects? That's important because there is a warning with romosozumab that it's not for patients who have had at least recent cardiovascular or cerebrovascular event. And when we look at the lower risk population, younger women in the FRAME study, we see that MACE events in patients on placebo in the first year on romosozumab versus those given romosozumab, the light blue being placebo, the dark blue romosozumab, there is no difference. And then as transitioned everybody over to the denosumab arm, again, no difference in MACE events even out to the 3-year clinical trial. You'll note that the risk of MACE events in this younger population is much lower, about 1%, as compared to those patients who are given, who are in the ARCH study, where in the first year, where all patients are on romosozumab in the blue, as compared to alendronate in the red, you can see that there is a difference and a significantly lower rate of MACE events in those patients on Romo as compared to alendronate. And that probably depended on the first 3 months and the latter 9 months of the study, where unusually there were very few cardiovascular events in the alendronate group, and there is that linear increase in MACE events, as you would expect from something that would be neutral to cardiovascular events in the Romo patients. And here you can see after the 1 year on Romo, there was no reduction. There's still that linear climb in MACE events out to the end of the study. And notably, at the end of the study, no significant difference in MACE events between those patients given the Romo upfront and those patients on alendronate from the beginning. And so we don't know the explanation for this. It is a warning that recent cardiovascular, cerebrovascular events in patients would be a contraindication to Romo therapy. This may be a chance finding. It's been proposed maybe alendronate protects from cardiovascular events, but there are further investigations that hopefully will clarify that soon. So on to guidelines. Where do we use these bone anabolic therapies and how can we utilize them effectively? This, as an example, is the American Association of Clinical Endocrinologists 2020 guidelines, and that's in line with guidelines that we've seen recently presented from the Endocrine Society, from the North American Menopause Society, from a number of new guidelines out there. And basically it recommends separating patients into those who are at high risk, perhaps with no prior fracture, versus those who are at very high risk, and certainly those with prior fracture or imminent fracture risk. And it suggests that that very high prior fracture population be a focus for the anabolics or parenteral anti-resorbers, that is, abaloparatide, romosozumab, or teriparatide as anabolics, or denosumab or zoledronate as a parenteral anti-resorber. So focusing in for that very high risk population on the anabolics or more potent anti-resorbers. And they went on to define who these very high risk patients might be. And this is clinically useful to identify these patients, those with recent fracture, imminent fracture risk, as it were, within the past 12 to 24 months, those who fractured well on osteoporosis therapy, those patients with multiple fractures or on long-term glucocorticoid. And they said, well, if your bone density T-score is very low, for instance, less than -3, or you have a very high FRAX risk that is greater than 30% for major osteoporotic fracture, or greater than 4.5% for hip fracture, then that would define the very high risk category where bone anabolic therapy would play a major role. A couple of slides on an agent, another sclerostin antibody, which is going to come to the fore perhaps with positive phase 2 trial results, and that is sestrusumab, which may be our first indicated therapy for osteogenesis imperfecta. And as you know, that's a defect in the type 1 collagen in bone, which, if severe, causes major disruption of the skeleton, even in infancy. And this sestrusumab clinical trial looked at adult patients with osteogenesis imperfecta who'd had a fracture in the last 5 years and were not on bisphosphonate, and it gave them monthly infusions of this sclerostin antibody called sestrusumab in a dose-dependent fashion, so up to 20 milligrams per kilogram. This is too high a dose to give by subcutaneous injection. And they found that the radius bone density in those given the highest dose had significant increases, as did the lumbar spine bone density. They found that, as with romosozumab, there was an increase in P1NP, similar to romosozumab, tended to auto-regulate or drop down toward baseline as one came to the end of 12 months of sestrusumab injections. And serum CTX also showed a similar pattern to romosozumab, with suppression that maintained out to the 12 months of monthly infusions of sestrusumab. So these are similarities to romosozumab sclerostin antibody. And we saw those increases in spine bone density and femoral neck bone density on treatment if given zoledronic acid after the 12 months of sclerostin antibody. Both spine and hip bone density were preserved or even slightly increased. And that compared to those patients who were not given zoledronic acid, who also had stable bone density. This is different from romosozumab. Radius bone density, whether patients got a zoledronic acid infusion after their year of sclerostin antibody, or if they didn't get zoledronic acid, in both cases they had declines back down to baseline, and that was the case with tibia as well. So that's interesting, and these findings in terms of resolution of effect of this sclerostin antibody are different from what we see with romosozumab. So that may be coming your way soon for the treatment of these patients with osteogenesis imperfecta. So in summary, I presented to you the effects of bone anabolic therapy and some recent data showing increases in bone formation, and that occurring with or without increases in bone resorption, depending on the anabolic. And I've shown you data on PTH and PTHRP analogs, which are remodeling-based bone anabolics, which increase bone formation within resorption space, differing from the sclerostin antibodies, which stimulate bone modeling, and that is new bone formation on quiescent surfaces, and have a dual effect, also suppressing bone resorption. And I've shown you about the bone loss or resolution of effect with romosozumab and teriparatide, as well as abaloparatide, and so these agents must be followed on by anti-resorptive therapy. And shown you where the role of anabolics may be more clearly defined in the future, in that they are capable of giving major effects on increasing bone density, particularly at the hip, and they are indicated as first-line therapy, where you get the biggest anabolic effect given prior to anti-resorptive therapy, particularly in these patients with severe osteoporosis. So I'll finish up with that and certainly welcome any questions during the discussion. Thank you.